Hello and welcome. In this lecture, we will take a look at diseases of the pericardium. The objectives for this lecture are as follows. Recognize the importance of the pericardium as an anatomical structure. Analyze the pathophysiology of pericardial disease. Identify key symptoms, physical findings, and diagnostics that may represent an underlying pericardial disease process. And finally, integrate pharmacologic and non-pharmacologic methods of manipulating pericardial pathophysiology. Let's begin by taking a look at the heart wall. Moving from superficial to deep, the heart layers begin with the parietal pericardium. Just below the parietal pericardium is the visceral pericardium. Between these two layers is the pericardial fluid, which functions as a cushion between the heart and the thoracic organs. Below the pericardium is the myocardium. And finally, the deepest layer is the endocardium. The best way to think of the pericardial layer is by imagining that you're pushing your fist into a balloon, allowing it to wrap around your fist. You can see how this would develop the two layers, the parietal and visceral pericardium, as well as create a pericardial cavity where pericardial fluid rests. The pericardium serves three functions, the first of which is a mechanical function. It promotes cardiac efficiency by limiting acute dilation, maintaining ventricular compliance with preservation of the Starling curve, and by distributing hydrostatic forces. The pericardium also creates a closed chamber with subatmospheric pressure that aids in atrial filling and lowers transmural cardiac pressures. The second function is the membranous function. The pericardium shields the heart by reducing external friction and acting as a barrier against extension of infection and malignancy. The third and final function is ligamentous. The pericardium anatomically fixes the heart. Let's take a look at our first condition, acute pericarditis. Pericarditis is inflammation of the pericardium due to infiltration of leukocytes. With all inflammation, there's scar tissue formation. This process occurs in this case where the pericardium has a fibrous reaction with exudates and adhesions. Acute pericarditis presents with myalgia or muscle pain, malaise, then chest pain that worsens with respirations and the supine position. There may be associated dysphagia, restlessness, irritability, anxiety, and weakness. On the exam, you may note a low fever that lasts several days. Auscultation may reveal a pericardial friction rub. In order to hear this, you may have to ask the patient to hold their breath while auscultating. This sound is produced by the pericardial membranes rubbing against each other. Pericarditis is often idiopathic in etiology. However, it's most commonly caused by viral and bacterial infections. It's important to note that viral acute pericarditis is the most common cardiovascular complication of HIV. Other causes of pericarditis include myocardial infarction, trauma, neoplasm, surgery, uremia with a BUN greater than 60 milligrams per deciliter, connective tissue disease such as systemic lupus erythematosus and rheumatoid arthritis, and radiation. The primary method of diagnosing acute pericarditis is through the 12-lead EKG or telemetry. Sporadically through these lectures, I will show you some key findings on a 12-lead EKG. In pericarditis, there is a concave upward ST elevation, shown by the blue arrows, and PR depression, shown by the red arrows. This finding may last days to weeks. The management of acute pericarditis is primarily based on symptom relief. You want to encourage rest, and the patient may be prescribed a combination of salicylates, NSAIDs, combined non-corticosteroidal agents, steroids, and colchicine. Colchicine's actually been shown to prevent fibrosis in patients with pericarditis. So essentially, you have less scar tissue. These patients may require fluid aspiration through pericardiocentesis if an effusion develops. Additionally, there are targeted therapies based on the etiology. In this 2014 study by Amazio and others, colchicine was shown to significantly reduce the recurrence of pericarditis due to reduction in fibrosis. You can see how this resulted in an initial 90% recurrence-free survival and tapered over 18 months, compared with the placebo group, which showed an initial 80% recurrence-free period that tapered over the 18 months. The next condition we'll discuss is constrictive pericarditis. In constrictive pericarditis, there's fibrous scarring with calcification of the pericardium, resulting in visceral and parietal pericardial adherence. This results in obliteration of the pericardial cavity, resulting in a rigid shell. The etiology of constrictive pericarditis is very similar to acute pericarditis. The manifestations of constrictive pericarditis are very similar to cardiac tamponade, which we'll discuss in a moment. But the symptoms are never sudden, and seldom there's a Pulsus Paradoxus. Patients may experience exercise intolerance, dyspnea on exertion, fatigue, anorexia, weight loss, edema, jugular venous distension, and hepatic congestion. A characteristic sign of constrictive pericarditis is a pericardial knock, which is an early diastolic sound. This occurs due to the restricted ventricular filling. Another sign that you may see is the Kussmaul sign. This is when you have an elevated jugular venous distension with inspiration. It's a nonspecific finding, but it does not occur in patients with cardiac tamponade. Let's take a moment to discuss Pulsus Paradoxus. While we talk about this, refer to the image of the heart and imagine the changes that occur. During normal inspiration, there's a decrease in intrathoracic pressure. This results in an increase in blood flow through the superior and inferior vena cava toward the right side of the heart. This then leads to an increase in pressure in the right side of the heart. Because the pericardium normally limits the left-sided heart's ability to dilate, there's a bowing of the atrial and ventricular septum towards the left heart. As you could imagine, if you shift the septum towards the left side of the heart, there will be decreased left ventricular filling. This then results in a decreased stroke volume, and therefore a decreased blood pressure. Normally, this drop in blood pressure during inspiration is less than 10 millimeters of mercury. Pulsus Paradoxus, on the other hand, is defined as a drop in the systolic blood pressure by greater than 10 millimeters of mercury during inspiration. This finding suggests restriction by the pericardium, either by calcification, fibrosis, or excessive fluid. In order to measure this, you'll want to inflate your blood pressure cuff and listen for the first carotid cough sound. Slowly deflate the blood pressure cuff, listening for when the carotid cough sounds no longer disappear with inspiration. At this point, determine the difference. I enjoy showing radiology images because it seems to bring the condition to life. In this image, we're looking at a chest X-ray that's showing calcification of the pericardial space. This echocardiogram reveals calcification, denoted by the harsh white discoloration, which suggests constrictive pericarditis. This final image is a CT showing a thick, calcified pericardium. Management of constrictive pericarditis includes sodium restriction, diuretics, especially loop diuretics, to reduce preload, treatment of associated arrhythmias, and a pericardiectomy, which is a surgical excision of the restrictive pericardium. Next, we will discuss pericardial effusion. A pericardial effusion is an accumulation of fluid in the pericardial cavity. By redistributing the forces around the heart, the pericardium plays a big role in the concept of ventricular interdependence, where changes in pressure, volume, and function in one ventricle influence the function of the other. Normally, as the right atrium and ventricles fill during inspiration, the pericardium limits the ability of the left-sided chambers to dilate. This contributes to the bowing of the atrial and ventricular septums to the left, which reduces left ventricular filling volumes and leads to a drop in cardiac output. As intrapericardial pressures rise, as does in pericardial effusion, this effect becomes pronounced, leading to a significant decrease in stroke volume and eventually progression to pericardial tamponade, which we'll discuss next. Symptomatology in pericardial effusion really depends on the rate of accumulation of fluid. A rapid accumulation of 80 milliliters may produce symptoms, whereas a slowly progressing effusion can develop up to 2 liters without causing symptoms. Pericardial effusion is manifested by chest pain that's relieved by sitting up and forward and intensified when supine. It may additionally be manifested by lightheadedness, syncope, palpitations, cough, and dyspnea. On exam, you may note a pericardial friction rub if the etiology is pericarditis. You may notice Beck's triad, which includes hypotension, muffled heart sounds, and jugular venous distension if the patient's progressing into tamponade. You may also notice diminished breath sounds if the patient's developed a pleural effusion. And some other common exam findings are tachycardia, tachypnea, and a low-grade fever. A sign that stands out in pericardial effusion is the Ewart sign, which is dull percussion beneath the angle of the left scapula from compression of the left lung by the pericardial fluid. Pericardial effusions have a variety of etiologies. They're primarily classified based on the type of fluid, whether it be exudative, transudative, serosanguinous, or frank blood. Exudative causes include pericarditis, cardiovascular surgery, chemo, infection, and autoimmune disorders such as systemic lupus erythematosus. Transudative causes include left heart failure, overhydration, and hypoproteinemia. Serosanguinous causes include tuberculosis, neoplasm, uremia, and radiation. A pericardial effusion with frank blood can occur from aortic root dissection, free ventricular wall rupture, trauma, and coagulopathy. This X-ray shows an enlargement of the cardiac silhouette, producing a water bottle shape. This suggests pericardial effusion. On an echocardiogram, you can see the fluid surrounding the heart in the pericardium. Even a large pericardial effusion may not be clinically significant, except that it represents an underlying pathology. The most important thing to note here is that sufficient pressure can cause cardiac compression. This is where you get cardiac tamponade. Management of a pericardial effusion depends on its etiology, but generally includes aspirin or NSAIDs, colchicine, steroids, potentially antibiotics, and a pericardiocentesis. Now let's discuss our last pericardial disease, cardiac tamponade. Cardiac tamponade occurs when pericardial pressure is greater than the intracardiac pressure. It essentially occurs when a pericardial effusion results in cardiac compression. In this case, the pressure in the pericardial space becomes so high that it restricts cardiac filling. The right atrium is usually altered first because it has the lowest pressure compared with the other chambers. This then results in decreased right atrial filling during diastole. So to put this into perspective, there's increased fluid in the pericardium, resulting in decreased ventricular filling, which results in a decrease in end-diastolic volume. This then results in decreased myocardial stretch or preload, as well as decreased myocardial contractility, which ultimately results in a decreased stroke volume and decreased cardiac output. In your notes, write a big E for medical emergency for this condition. Remember how we were discussing ventricular interdependence in pericardial effusion, where changes in pressure, volume, and function in one ventricle influences the function of the other. This effect is severely exaggerated in cardiac tamponade. During inspiration, the right atrium fills and exerts a lot of pressure on the atrial and ventricular septums. This is worsened by the excess fluid around the heart. The septums deviate towards the left side of the heart, reducing left-sided filling and producing a drop in cardiac output. During expiration, the positive intrathoracic pressure is exerted on the already fluid-filled pericardium, resulting in right-sided heart collapse. When this occurs, you can imagine how this will decrease blood flow through the normal circulatory pattern through the heart. The problem is the severely reduced cardiac output as a result of compression on the heart. The manifestations of cardiac tamponade are frequently organized into a triad, referred to as Beck's triad. Beck's triad includes jugular venous distension, muffled heart sounds, and hypotension. Jugular venous distension is a measurement of right atrial pressure and correlates with the central venous pressure. Because of the high pressure exerted on the right atrium, the jugular vein distends. Heart sounds are muffled in cardiac tamponade because of the excessive fluid around the heart, creating a distance between the heart and the stethoscope. Hypotension occurs due to the decrease in cardiac output. As a result of hypotension, compensatory tachycardia occurs in order to increase cardiac output. And finally, Pulsus Paradoxus occurs with the reduced cardiac output during inspiration. On the chest X-ray, you'll see the same water bottle effect with the cardiac silhouette as you would see with pericardial effusion. On the echocardiogram, patients with cardiac tamponade will have increased pericardial fluid, which is the same finding that you would see in pericardial effusion. However, in cardiac tamponade, you'll notice that the right atrium and right ventricle collapse. The heart will also be swinging back and forth as it floats freely in the pericardial fluid. This is referred to as a swinging heart. I described all of those changes on the echocardiogram not only to demonstrate the pathophysiologic changes, but also to help you make sense out of the changes you'll see on an EKG. First, you'll notice that the patient's tachycardic. This is consistent with the compensatory tachycardia as a result of decreased cardiac output and hypotension. Second, you'll notice small QRS complexes throughout the EKG. This is referred to as low voltage. This is consistent with the compression on the heart during cardiac tamponade, which limits forceful contraction. Finally, there's a characteristic finding referred to as QRS alternans. This is best demonstrated on lead V5 on the bottom of the EKG. QRS alternans occurs because the heart is free-floating within the pericardial fluid. When the heart contracts, it swings back and forth, moving it closer and then further away from the electrode. When this occurs, it produces alternating large and small QRS complexes. General management for pericardial effusion and tamponade include analgesics, anti-inflammatory meds, and steroids. Additional therapies may be implemented based on the etiology. I briefly mentioned pericardiocentesis earlier. This involves aspiration of excessive pericardial fluid, and it also helps determine the fluid type for diagnosis. In recurrent cases of pericardial effusion or tamponade, a surgeon may have to create a pericardial window or perform a pericardectomy. During a pericardiocentesis, a needle is inserted between the xiphoid process and left costal margin at about a 30 to 45 degree angle. The proceduralist will aim for the left midclavicular line and direct the needle towards the anterior wall of the right ventricle. At this point, the proceduralist can aspirate fluid. This last image shows a pericardial window, which can allow for drainage of the pericardial fluid.